is Bill Beck, and I'm the Director of Audiology here at the University of Texas Health Science Center. I'm a member of the faculty of the Department of Otolaryngology and Head and Neck Surgery. I'm an audiologist. My area of interest is hearing and balance problems. I've been here at the Health Science Center for about 4 years, and very much like Dr. Zayak, I was a military officer. I was an audiologist in the Army. As a matter of fact, Dr. Zayak and I worked together for 3 years earlier in the 90s. This presentation is Diagnosing and Managing Hearing Loss, and I've in essence retitled this Challenges of the Aging Ear. Okay. A reasonable place to start in talking about hearing loss is to try and get a feel for that. And I have to start by asking a question, and so I'll ask someone here, what is the population of the United States?
10 billion.
Not even close.
Not even close.
Not even close. It's about 283 million. There's an interesting website that you can find that will keep you up to date. And
There's an echo in here.
there is some feedback. It's going to make my talking a little bit challenging. Delayed auditory feedback makes you stutter. It doesn't help very much in talking. But in any case, the population of the United States is about 284 million. There's an interesting website that can keep you up to date with the increase in the population, and it's about one individual every 17 seconds. And so the number that I have is from last week, and we'll just round that up to 284 million. So how much of that population is elderly population? We'll define that as being 65 years or older. And the answer to that is it's somewhere in the neighborhood of 12 to 13%. So for this year, it's somewhere in the neighborhood of 34 to 37 million people are aged 65 or older. When we begin to talk about hearing impairment, at birth, we identify between 1 and 6 infants per 1,000 who have significant hearing impairment. And so that's a pretty small number, less than 1%. But by the time we reach age 65, we're looking at about 30% of that population having some hearing loss, or at least admitting to that hearing loss, which is not exactly the same thing. So we come up with a number of about 11 million people in the United States who have significant hearing loss once they've reached the age 65. So that's a substantial number of people. The prevalence of hearing impairment is rather significant. It's the third most often identified medical condition that people have. It's actually the second most frequent medical condition for elderly males. It's the third for females, and because of the way things average out, it's going to be identified right after arthritis and hypertension as being a medical condition that requires attention. Now, what we call hearing loss as a part of the aging process is presbyacusis. And it's important to know what the characteristics are so that it can be differentiated from other hearing impairment that might be pre-existing or that might arise that is not the result of simply the aging process. So the characteristics that we look for is that, first of all, that it's a nerve hearing loss, a sensory neural hearing loss. And the way that we're going to identify that is through hearing testing. The hearing loss should be in both ears. It should be bilateral, and it should be about the same amount. The hearing loss that occurs from the aging process is progressive, but it should be gradually progressive. We're looking for other kinds of conditions when a person says, well, my hearing has changed, but it's only changed over the last few days, the last few weeks, the last few months. The hearing loss from the aging process is very slow, very gradual, and quite often from month to month or year to year, the elderly population would say that their hearing really hasn't changed when hearing tests might show something entirely different. Now, this is what hearing loss from presbyacusis looks like, but it's not a very good place to begin. I need to spend a little bit of time talking about how it is that we record hearing loss. The test that you will most likely be familiar with is what we refer to as pure tone testing. We present tones of different frequencies and different levels individually to each ear, and we try and identify the level that the patient can just barely hear the tones, and then that's recorded on this diagram. So as you look at this particular figure, if you look at the horizontal axis, those vertical lines with the numbers represent pitch. So 125 represents a tone that we use, a low-pitched tone that we use in conducting a hearing test. 1,000 hertz is a mid-pitched tone, and we test all the way up to the higher frequencies, up to about 8,000 hertz. The symbols that you see displayed on the figure identify the hearing test results for the right ear and for the left ear. The red circles that you're going to see on the diagram represent the hearing test results from the right ear. The blue X's represent the hearing test results for the left ear. And where those symbols are located on that diagram represent how loud each one of those tones had to be made for the person to just barely be able to hear the tone. Now, also displayed on this particular figure are these lines which represent the sounds of speech. Speech is made up of low-pitch, mid-pitch, and high-pitch sounds, and some of those sounds are soft, which are represented by these lines that up towards the top of the diagram, and some of the sounds of speech are loud. And so we can see, traced by this line that's lower in the figure, those represents the sounds of conversational speech. When we are conducting a hearing test, we've identified the levels at which the person is just barely able to hear the sounds. We try and relate those hearing test results to the amount of communication handicap that's likely to be caused by that amount of change in hearing. So when a person is able to hear very soft sounds, then we're going to refer to that as normal hearing. And on this particular diagram, the range of normal hearing would be from 0 decibels up to somewhere in the neighborhood of about 20 decibels. When the sounds have to be made louder than that, then a hearing loss is present. We might refer to that as being a minimal hearing loss or a mild hearing loss. And as the hearing test results show more and more hearing loss, then we would identify the hearing loss as being severe and profound. Profound hearing loss would be the same thing as what has been used in the past, or the term that's been used in the past is deaf. Even deaf people are able to hear sounds in most instances, although the sounds have to be made very loud. So the term that we use is profound hearing loss, and this category, these group of categories that we use, normal, minimal, mild, through severe and profound hearing loss, what we're trying to do is to relate the amount of communication handicap that is actually caused by that amount of hearing loss. A person who has a minimal hearing loss or a mild hearing loss is very likely aware that they have some hearing difficulty, but it doesn't cause them too much problem. When a person has a moderate, a severe, or a profound hearing loss, then sounds just aren't loud enough for them to be able to hear and to understand very well. So returning to our hearing test results for presbyacusis, this information is from one of the large population studies that was reporting on, I believe, heart disease, but various other health conditions were being monitored in this population also. And hearing test results were performed on a large number of people, and what we find is that that the males and females at 65 to 69 years of age, their average hearing impairment is within the normal range, up to about 20 decibels through the low and mid frequencies, and then there's a mild hearing loss for the females. There's a mild to moderate hearing loss for the males. When we look at the population as they have now reached the ages of 80 to 89, then there's substantially more hearing loss, and these are people who most all of their hearing is outside the normal range for low frequency, mid frequency, and high frequency sounds. So by the time our population has reached 80 years of age, there's substantial hearing loss, significant hearing loss, something needs to be done, and there's a good portion of the population much younger than that, by age 65, who have enough hearing loss that they're first of all having difficulty, and secondly, need help to be able to hear better. It's very difficult to describe to someone just exactly what the effect of a hearing problem is. With vision, you can simply provide a blurred image and then show what the effects of correction are going to be. But it's not very easy to give a simulation, a sound simulation, an auditory simulation of the effects of hearing loss. So what I've tried to create with this particular slide is a visual analogy. So if you can imagine for a moment that when a person has normal hearing, speech can be loud and clear, and that's represented by something that's very easy to read and is of a fairly large-sized lettering. When a person has a sensorineural hearing loss, then, first of all, the amplitude of the sound, how loud the sound is much smaller. And so that's represented in the size of the text that's present. And then the other condition that is present is even if the person can hear the speech, it's not very clear. And indeed, that's the way that the elderly population is going to oftentimes describe their hearing loss. Even if they only have a mild sensorineural hearing loss, a mild nerve hearing loss, they're going to be saying something like, I can hear when people talk, I just can't understand what they say. They can hear the low pitch and mid pitch sounds because usually their hearing is still within normal limits, but a good portion of the information of speech is concentrated in the mid-frequency and the high-frequency sounds, the mid-pitch and the high-pitch sounds, the consonant sounds. Those are the sounds that they don't hear as clearly, and so what the elderly population experience then, or a person with a sensorineural hearing loss is going to experience, is that they don't understand the differences between words. And the examples that I often will use is something like pin, tin, kin, fin, sin. The only differences between all of those words are high-frequency sounds, the difference between p, they're first of all high-pitched sounds, and secondly, they're the softest sounds of speech. And so a person begins to have difficulty understanding the message because they're not hearing as well in the mid-pitch and the high-pitched sounds, even though they can still hear the person's voice because there's a there's good hearing for the low-frequency sounds, which are the louder sounds of speech, but they don't have as much information. So then what's the effect of the hearing loss? Well, one of the effects of hearing loss as it develops is that it places the person in greater and greater isolation. They begin to experience a separation between family and friends because they're having more difficulty communicating, being able to understand and be understood. This can lead to not enjoying recreational activities as much. Many of the activities that we participate in as adults, as elderly adults, depend on communication. We do things for fun where we're communicating with other people. And then if we begin to have difficulty understanding the people that we're participating with, that's not as much fun. We don't enjoy it as much. And you'll begin to see an elderly person developing a hearing loss is changing the patterns of the things that they do. They stay away from social activities where there's a lot of background noise, for instance, because it's just not as fun anymore. And so then the person who's developing the hearing loss is participating in fewer and fewer interactions. And so there's this tendency towards isolation as the hearing loss develops. And if it's developing in one member of a married pair, one of the spouses is, well, they're not as much fun to be with, they're not as willing to go out and participate in activities and so forth, and it really begins to change some of the important social interactions. In the elderly population where there is hearing impairment present, those individuals tend to report more symptoms of depression. And if there are other coexisting cognitive problems, the communication impairment that comes with the hearing loss really just makes that worse. So you need to understand, you need to appreciate that our hearing is, our ability to communicate well is the basis for so many of the different things that we do. It's really the foundation of our quality of life. And if the hearing is diminishing, if our ability to communicate and to interact through speech and hearing is diminishing, then certainly the quality of life is going to suffer. And this can be quite obvious in patients who experience dementia, Alzheimer's disease, that if there's a hearing impairment, if there's poor communication, a person who's having difficulty interacting with other people and with their environment, the hearing loss just makes the conditions worse. And indeed, for some patients who have Alzheimer's, and it's a challenging process, but if they can be fitted with hearing aids that are able to improve their ability to communicate, then oftentimes some of the accompanying symptoms are not as severe. So it becomes important to see what can be done to solve some of the communication problems of the elderly, regardless of what other problems they might be experiencing. So who participates in the process of trying to manage the people who are experiencing hearing problems? Well, the primary care provider has an important role in terms of hearing screening and the first steps of oral hygiene, and why that's important we'll discuss here in just a moment. The audiologist is an important provider of services to the hearing impaired. We are the specialists who are going to provide the evaluation of hearing. We're going to provide the non-medical management of the hearing difficulty. And quite honestly, presbyacusis specifically, but most of the sensorineural hearing impairments are not medically treatable, so the audiologist is involved in the management of the large majority of hearing problems. And then, of course, there is going to be ear disease present, either pre-existing ear disease, and certainly it doesn't go away as we get older, and there's an important role for the specialist, for the otolaryngologist or the otologist, in terms of providing medical management of the conditions that do occur in the aging population. Well, hearing screening is one of the important functions of the primary care provider, and we need to look at how that can be done best. And a place that I like to start is with the things that don't work. Unfortunately, although these are oftentimes reported as means of screening the hearing impaired, the whispered voice test, the watch tick test, the finger rub test, these screening procedures really are quite limited in what they're able to do. They do not assure that that portion of hearing function that is being screened is that part of the hearing that is important to communication. So while a person may have difficulty with the whispered voice test, or they may pass it, what is your name? What's your birthday? The person who's conducting that kind of screening oftentimes has not been trained in a way to control their voice so that they know exactly what level that they're speaking at, how far away they are from the person that they're trying to screen, and those sorts of things. And you have to understand that when you have a female physician or a female primary care provider who is conducting the whispered voice test, and you have a male primary care provider doing the same thing, they're not conducting the same test. Whereas you can have audiologists conducting hearing testing, and because the equipment is calibrated and testing is being performed in a controlled listening environment, then it doesn't really matter which audiologist is conducting the hearing test. If we have a reliable patient, we'll get the same test results for estimating that patient's hearing. The finger rub test is rubbing your fingers close to the ear, and there is a sound there. It's a very high frequency sound, and that is where we want to be screening, but unfortunately how close you are, how hard you press your fingers together, and just how much surface resistance there is, it all plays a part in what the frequencies, what the pitch of the sound is, and then how loud that sound is. And then tuning fork tests. Tuning fork tests are not tests of hearing sensitivity to say, do I need to refer for hearing loss or not? They are important and provide information on the kind of hearing loss is present, separating between sensorineural and conductive hearing loss, for instance. But it is not something that we would use for screening. Does this patient have enough of a hearing impairment that it's time to make a referral for a more thorough evaluation? Okay, so what does work? Well, one of the first things that we need to consider is getting the earwax out of the ear canal. Most of the patients who come in who have hearing problems hope that this is their problem because it's very easily fixed and then their hearing is perfectly fine. Well, in the elderly population, keeping the ears clean so that it does not contribute, accumulation of earwax does not contribute to hearing loss is important, but what usually is the case is that there is this accumulation of earwax and it's affecting the hearing, and there's a sensorineural hearing loss that also has to be dealt with. Then pure tone hearing screening and self-assessment questionnaires both are the techniques that are going to provide the accurate information for determining whether or not it's time for a particular patient or particular individual to be referred for additional hearing testing. Now, cerumen removal is important. It can provide as much as a 10 to 15 decibel hearing loss. If a person already has a minimal or mild hearing loss, and on top of that an additional 10 or 15 decibel hearing loss, you've just moved a person from being sort of a borderline candidate for hearing aids, a person who can probably get by without them but might benefit from them. You've moved them into the category of having a moderate hearing loss where they really can't hear without hearing aids. And so it's a significant enough hearing loss that when it is managed that it makes an improvement. Usually it's just not enough. I don't want to refer to them as disadvantages, but the requirements are there is special instrumentation. It takes time. Oftentimes in the primary care setting, cerumen management cannot be completed in just one visit. there's going to be challenge to removing the cerumen, if it's really hard and so forth, and earwax softening agents need to be applied. That needs to be done over a period of days or weeks, and then the earwax cleaning is completed. And then there are real risks. You can actually cause injury in the ear canal trying to remove the wax. If there's an unidentified perforation of the eardrum and an irrigation technique is being used, you can actually create an ear infection that wasn't present. And then one of the serious complications that needs to be considered when we're talking about the diabetic population is one of the serious complications of external ear infection can be necrotizing otitis externa. It can be a life-threatening infection, requires medical management by the specialist, and if that condition is already existing and irrigation techniques are used for cerumen management, you can actually make the condition much worse. So the primary care provider has to be confident that he or she is going to be successful in cerumen removal techniques, and it probably requires a bit of practice under the supervision, for instance, of an otolaryngologist to learn exactly what to look for when examining the external canal before removing cerumen, and then what the techniques are. There are actually two different techniques that might be employed. One of them is irrigation, where an irrigation bottle is filled with solution that is at body temperature, and it's used to lavage or to wash out the external ear canal. There are over-the-counter systems that patients will sometimes use on their own that include drops that are cerumen or earwax softening agent, and then a bulb syringe to use in trying to wash that out. It's always important after that irrigation cerumen management to dry out the ear thoroughly. The other technique is to use a curette. Use an instrument in which the cerumen is actually removed from the ear canal. This is unfortunately a figure that was in a publication that doesn't display what ought to have been displayed. I will simply mention to you that anytime the cerumen is this close to the tympanic membrane, the only person who ought to be removing that is an ear specialist who does this procedure under a microscope. This is not something to be done in the primary care setting or by someone who doesn't have a lot of experience working in the external auditory canal. Okay, so the next question, should the primary care provider screen for hearing impairment? What does our best evidence tell us? And the answer to that is very definitely yes. There are valid and reliable techniques for performing hearing screening, and when hearing loss is suspected, hearing impairment is suspected, the referrals actually are very accurate, and once the hearing loss has been identified, is there anything that we can do for the condition anyway? And the answer to that is most certainly yes. What has been reported in the literature as providing the most reliable means of identifying hearing impairment is a hearing test instrument. Welsh Allen, which makes the instruments that are used for the examination of the external ear, provide an otoscope, an ear light, which has a sound source built into it. The otoscope can be used to visualize the external auditory canal and the tympanic membrane, so you can do that visual examination of the external auditory canal. And then the sound source, which has been calibrated, presents the pure tones at levels that can be controlled. The patient during the examination is asked to listen for the tones and respond if they hear them. And if a screening level of 40 decibels is used to identify that a person has, or that a suspicion of a hearing impairment is present and the person needs to be referred for additional testing, the sensitivity of using the instrument has been reported to be anywhere from 87 to 96%, and the specificity between 70 and 90%. So it's a very good screening tool in comparison to the other things that we can do. Certainly it is reliable, certainly it is a useful tool, where the whispered voice test and the watch tick test and so forth are not so good. An alternative for screening hearing are self-report questionnaires. One of the ones that has been investigated is the Hearing Handicap Inventory for Adults and the Elderly, the screening versions, which is the -S. In the handouts that were prepared for this particular presentation, I've included the HHIE in both its English language and Spanish language forms, so that you have a chance to look at those. It's a series of 10 questions that ask about the patient's ability to hear and their emotional reaction to the difficulty that they might have from communication problems. Questions like, does a hearing problem cause you difficulty when listening to TV or radio? And the patient responds to the question, either yes, sometimes, or no. If the patient reports yes, that answer, that response is scored as 4 points. If they say sometimes, it's scored as 2 points. If they say no, no points. All 10 questions are answered, the scores are totaled, and when the scores reach above 8, then hearing loss should be suspected. When it has been used as a screening tool, its sensitivity is not quite as good, 53 to 72%. Specificity is still comparable to that of the audioscope, 72 to 84%. So for individuals who do not have the audioscope available, it certainly is an instrument that costs some money. If the primary care provider is not able to invest in that instrument, this is certainly a satisfactory alternative for simply identifying when a patient comes in saying, I think I have hearing problems, or in annual evaluations and as a means for trying to determine who should be referred for additional testing. Certainly these screening instruments do a good job of identifying those people who would benefit from additional hearing testing. Now, I've also included in the handout, not so much as an instrument to be used, but it's interesting that in completing this particular investigation, Ruben and his associates went to the data that was reported in the National Health and Nutrition Examination Survey. It was actually information that was being collected on an elderly population from 55 to 74 years of age about their health and nutrition, but it included for groups of these individuals responding hearing test results and so forth. And what they tried to do was to identify what characteristics of the population would be a pretty good indication that the people have a hearing impairment. And the comparison of their series of 7 questions, they were able to establish a sensitivity for the instrument of 80% and a specificity of 80%. And what they identified was that within this group that was responding, that when a person was over 70 years of age, they were assigned 1 point. If they were male, they were assigned 1 point. If their education was the 12th grade level or less, they were assigned 1 point. If the individuals had ever visited a physician for a hearing-related problem, they were assigned 2 points, and then there were 2 additional questions about whether or not they could hear whispered speech across the room or when the speaker's face was not visible to them. And so anytime 3 points or more was accumulated, then that was an indication of a significant hearing loss. I'm not sure that I would necessarily recommend this as being an instrument, but it gives you an idea what some of the characteristics of the population are that are going to be a fairly good indication that additional hearing testing, that hearing loss is present and additional hearing testing would be beneficial. When our patients reach the age of 70, males more than females, education has, I'm sure, more to do with the kinds of jobs that people hold. That they are more likely to have worked around high-level noise, they're more likely to have lived a life that is likely to have contributed to sensorineural hearing impairment, and then once a person reaches an elderly age and they've been to the physician because they've had some sort of ear problem, then usually that's a person who already had a hearing loss, so it sort of makes sense. But in any case, these are the kinds of characteristics that when seen in patients should be a fairly good indication that the hearing loss is likely to be present and needs some management. So hearing rehabilitation, what can we do about the problems? Well, first of all, doing nothing doesn't work. If a hearing problem is present, then we need to do something about that. What does work? Well, one of the things that we want to be able to do is we want to be able to train our patients and the people who communicate with them about improved listening skills. Some of this is accomplished by hearing impaired people on their own, where they notice that they don't hear as well in church, for instance, and so they choose to sit in a different location. And what they're actually doing is trying to find a location where they get some additional visual cues. When they are out and communicating with people and there's background noise, turning their back to the noise sometimes helps the person with the hearing impairment to hear better. And so there are different things that can be done in the early stages of hearing impairment, or when a person with a hearing loss, maybe as a hearing aid user, can still benefit from achieve better hearing if they can do something to manage the listening environment. So one of the things that we talk to our hearing impaired patients about is the things that they can do on their own to try and improve the ability to communicate. And sometimes that means don't communicate. If you're having difficulty in the car, carrying on a conversation, and the hearing impaired person is the person who's driving. If they're going to get visual cues by looking at the person that they're speaking to, maybe they ought not to do that. And so that's simply an example of a listening environment that we discuss with our patients who have hearing impairments, making suggestions about when it's a good time to communicate, when it's not, when a hearing impaired person has control over the listening environment when they're at home and they're trying to have a conversation and the TV's on, or they happen to be in the kitchen where there are appliances that are making noise and so forth. We say, get out of that noise environment. Just by taking away the background noise is going to help improve the listening environment. So before a person reaches the point where they're using hearing aids, or while they're using hearing aids and they're still having hearing difficulty communicating, which of course they will, then if they can control the listening environment, move away from background noise, make sure that they can always see the person that they're speaking to, all of these things are going to help. What else is going to help? Well, hearing aids and what we refer to as assistive listening devices or special purpose hearing aids. But as we begin to discuss hearing aids and the other listening devices that can help, it's important to understand that the patient, the person with the hearing impairment, has to be motivated to use the hearing impairment. If it's just the spouse or if it's just the children who are motivated for the person with the hearing impairment to get hearing aids, that's a person who's not going to be a successful hearing aid user. I use this series of pictures just to remind us where we've come from. We're in the 21st century now, but as recently as 2 years ago, ear trumpets were just less than 100 years away from the time that we were using. Carbon hearing aids were the first electric hearing aids. The wearable forms were not available until the late 1920s, early 1930s. Vacuum tubes were introduced and worked into hearing aids in the 1930s and 40s, and after that we had transistor-based hearing aids. And we're to the point now where they can be quite small. One of the questions that's always asked by a person who is first considering hearing aids is, what's the difference? And quite honestly, as we look at the different types of hearing aids that are available, the behind-the-ear instrument, the all-in-the-ear instruments, which include those that fill up the concha completely, and then the smaller versions, all the way down to the completely in-the-canal hearing aid, which is inconspicuous. Most hearing aid manufacturers make all of these different styles, and they're pretty much able to put any of the circuits that they manufacture into any of the packages of hearing aids. So the real answer to the question, what's the difference, is there is no difference except for what the case looks like. And the one exception to that is one of the newer developments in hearing aids that is quite beneficial is the two-microphone system. When people who wear hearing aids complain about not being able to hear very well in background noise, one of the things that really does help is to put a second microphone on the hearing aid and then introduce a type of circuitry that uses the information from those two different microphones to combine and actually improve the signal-to-noise ratio so the person can actually hear better in background noise. That requires space, and so that's usually only available in the behind-the-ear instruments and in some of the larger in-the-ear instruments that are available. What are we trying to accomplish when we fit hearing aids? This again is the audiogram that we were looking at before. If you can recall for a moment the sounds of speech, which are very soft and not really audible to the person with the hearing loss, these lines here, we try and take that speech sound and we make it louder. So that means that it comes down lower in the diagram. We push it above the softest sounds that the person can hear. But keep in mind that as we're trying to accomplish that, first of all, we can't get all of the sounds of speech into that audible range so that they're all easy to hear. And then the other problem that we face is that as a person develops a sensory neural hearing loss, oftentimes their loudness discomfort levels, and those are the loudest sounds that they can tolerate, become lower in level. And so we're trying to squeeze speech into a narrow range. And so that's one of the reasons why even though hearing aids are able to make speech louder, they're limited in their ability to make speech clearer. Now, part of that limitation is the damage in the inner ear that occurs from presbyacusis, from the loss of the sensory cells in the cochlea in the inner ear. But part of that is the fact that speech is made up of low, mid, and high-pitched sounds that are soft and loud, and it's very difficult to squeeze those sounds of speech all into what's remaining in terms of what the person can hear, which is the hearing loss, versus this, the loudest sounds that they're able to tolerate. Some of the questions that are answered, or that are asked and that we try to answer for people who are considering hearing aids. Can hearing aids help? Well, they help most hearing losses. Most of the people who have hearing loss, who are having difficulty communicating when it's not a medically treatable condition, are going to benefit from hearing aids. We get the question, how many hearing aids? One hearing aid or two? And the answer to that is really two are better than one in most instances. When two hearing aids are being recommended, the person selling the hearing aids, and that is what's happening, hearing aids are being sold, they're not trying to double their profit by recommending two hearing aids when a person can get by with one. We start out with two ears for hearing. We can hear better in background noise and from distances with two ears. And so when a person has a hearing loss in both ears and hearing aids are appropriate, then in most instances, the individual is going to hear better with two hearing aids than with one. Now, there's no question that hearing aids are expensive, and that most insurance plans either do not provide coverage for hearing aids or they don't provide very much coverage for hearing aids. And so most individuals who would benefit from hearing aids are on their own in terms of trying to cover the expense of the hearing aids. And then the other problem, this gets back to the need for motivation of the person with the hearing impairment, is learning to use hearing aids is work. It's not a matter of just fitting the right hearing aid to the person and they walk out the door and within a couple of days they're receiving all the benefits from hearing aids. A person goes through a change in the sounds they hear as a hearing loss develops. And then when hearing aids are provided, amplified sound is provided, there's a learning process that takes place in terms of the person being able to make use of the information that the hearing aids can provide. And it goes on for quite a long period of time, probably months, maybe even years, of the person listening to amplified speech and gaining more and more information from the amplified speech that the hearing aids are able to provide. Now, an interesting study that was reported in 1995 dealt with why hearing impaired individuals reject hearing aids. It was a study that included 100 subjects that were 65 years or older, and they were divided into 4 groups, or recruited into 4 groups. One of the groups of 25 subjects was a group that had normal hearing. Another group had never used hearing aids before. The third group had used hearing aids for a trial period, which was about 1 month, but decided not to continue to wear hearing aids. And then the fourth group were 25 hearing aid users who used hearing aids all the time. And this study reported the reasons that people using hearing aids chose or either did not like the hearing aids or chose not to use the hearing aids. And the top 5 reasons included complaints that it was difficult to manipulate the hearing aids. The hearing aids are small. As we get older, our tactile sensation is not as good, and trying to get a small device into a location in our head that we can't visualize, that we can't see, is sort of challenging. And being able to manipulate volume controls is also somewhat challenging. Yes, it is. Okay, yeah, they haven't cut out the mute or turned on the mute. Okay, and the other complaint that was similar to that was that it made sounds too loud. Now, the fourth and the second reasons for rejection had to do with the way hearing aids are sold. And unfortunately, this is something that our elderly patients have to deal with. And it makes the hearing aid purchasing process very unpleasant. The people in this particular study reported that they felt as though the practices that the hearing aid dealers employed were deceptive, and that there was a lot of high pressure placed on them to make purchases. The third most commonly reported reason for rejecting the hearing aids was that they amplify background noise. And indeed, that is a problem that all hearing aid users have to deal with. And this is a problem that is part of that adjustment process, or getting used to the hearing aids, is that people who experience hearing loss don't hear a lot of environmental sounds, background sounds, and as they start to use hearing aids again, they're put back into this listening environment where there are sounds present that they didn't have to listen to before, and it is sometimes bothersome, but it takes some getting used to. But the number one reason for rejecting hearing aids, and where I wanted to get to, is that what our patients tell us is that they cost too much. And it is a problem that is not easily dealt with. I can tell you that the hearing aid market, the manufacturing market for hearing aids, is quite competitive. And so if there was a manufacturer out there who could sell hearing aids for a lower price, they certainly would do it because they would get most of the business. And one of the reasons that hearing aids are as expensive as they are is that the size of the market, the people who are buying hearing aids, is in the tens of thousands as compared to automobiles and appliances and so forth, where the manufacturers of those products are selling millions of products throughout the United States. And then something else that adds to the cost of hearing aids, but is nevertheless important and very valuable, is that a person can purchase a hearing aids and then return them after a trial period, usually of at least 30 days. That's required by rules of the Food and Drug Administration and is written into the licensing laws of audiologists and hearing aid dispensers throughout the United States, that a trial period is required. And that causes the price of hearing aids to be higher too. But there's no question that the expense of hearing aids has to be dealt with, and that simply puts pressure on the elderly to solve the difficulty that they have, that they're faced with hearing loss through the purchase of hearing aids. Now, besides hearing aids, one of the other things that can benefit communication are what we refer to as assistive listening devices, and these can really just be thought of as special purpose hearing aids. Amplified telephones. If a patient comes in, they have a sort of a mild or mild to moderate hearing loss, and they're likely to be sort of a borderline candidate for hearing aids, but they're reporting difficulty being able to communicate on the telephone, then certainly an amplified telephone is one of the things that's going to help solve that problem. If they're having difficulty listening to the television, captioning on televisions, or the TV listening devices that can be attached to the audio output of televisions and provide earphones that have a volume control on them for the hearing impaired individual, can make a difference in just solving that problem. The patient says, you know, I have trouble listening to TV, or when I turn up the volume control, the people who hear better than I do in my family are not able to stay in the same room with me. These are the kinds of products that can solve those kind of problems. And then with the introduction of the American with Disabilities Act, all public places are required to provide access to people with disabilities, hearing loss being a disability. So more and more we find in public theaters, museums, and churches listening systems that can be used either with hearing aids or instead of hearing aids. They're usually based on an infrared broadcast system or an FM broadcast system, and it allows the person to have their own listening system, their own set of listening earphones, and a volume control that they can adjust. And then for people who have difficulty being awakened or alerted when when the phone is ringing, or someone at the door, or when they're sleeping, their smoke detectors and so forth, then flashing lights are the kinds of alerting devices that are essential for solving those kinds of problems. One of the problems that people with hearing impairment face at all ages, but certainly it becomes more frequent in our elderly population, is tinnitus, or tinnitus as it is sometimes pronounced. Those are the head noises, the sounds that we hear in our head. It's a ringing sound or a buzzing sound, a humming sound, a hissing sound that usually accompanies different types of hearing impairment. There are two different kinds or two different classifications of tinnitus. One is objective, and it is not seen very often, but it's a sound that the patient reports, the patient can hear, but it can also be heard by other individuals if they have a listening device that allows them to listen into the external auditory canal. As I said, this kind of tinnitus is rare, and it's usually vascular in origin. Sometimes a patient will report that they hear a sound and it's in the same rhythm as their heartbeat, and it can be a change in vascularity, arterial bruit, dehiscence around the jugular bulb that results in the flow of blood in the jugular bulb becoming audible. Oftentimes these are medical conditions that require a rather thorough evaluation just to be able to determine how serious they are. The more common types of tinnitus are the subjective tinnitus, which is the ringing, buzzing sounds and so forth. Sometimes when it is of sudden onset, an examination of the external auditory canal identifies that it's just an accumulation of earwax, and when that's removed, then the tinnitus goes away. Sometimes tinnitus will accompany an ear infection, otitis media with effusion, for instance, and then when that medical condition is treated, it goes away. But most of the tinnitus that people complain of, that they notice, is of sensorineural origin. Sensorineural hearing loss is present. Because that's a permanent hearing loss, then more often than not, that tinnitus is going to be a permanent condition also. When it's first reported, if a person has not had tinnitus before, and then during an examination with a primary care physician, the patient reports that they now have the sound in their ears, that's the time for a complete audiologic evaluation. If there's cerumen present, it needs to be removed. If there's middle ear disease, it needs to be treated. Something else to consider is whether or not there's been a recent change in medications. Tinnitus is perhaps the first or second most commonly reported side effect to medications, and if there's been a recent change in medication, sometimes that it is related to, or tinnitus onset is related to that, so that needs to be evaluated. Once you have all the information about the hearing and so forth, at that point, whatever treatment needs to be initiated should be, and if it's not obvious what the cause is, then otologic consultation needs to be considered. The treatment of tinnitus. Well, first of all, tinnitus is not going anywhere. If it's related to, associated with a sensorineural hearing loss, it's always going to be there. If a person has not worn hearing aids before, they have a hearing loss that is aidable, then that needs to be considered. And the reason for this is, first of all, it solves communication problems, which may be the more important underlying condition that's present, but also it puts the person with the hearing impairment more into their listening environment by amplifying environmental sounds and so forth. A person who has tinnitus doesn't notice it as much when they're in the presence of background noise. The background noise covers it up. And so there is a chance that with the additional amplification provided by the hearing aids that it's going to cover up the tinnitus, or at least draw the patient's attention away from the tinnitus. It's important to say to a person who is reporting difficulty with tinnitus that they need to avoid quiet. That's when it's most noticeable. And oftentimes a person will say that they notice it most when they're going to sleep at night. That's when their environment in the home is quiet and the tinnitus is more noticeable. And so there are ways of introducing sound. If a person is sleeping in a room and they can turn on a fan, that sometimes is enough background noise that it draws the patient's attention away from the tinnitus, and it's not so disturbing to their attempts to try to sleep. Sometimes we advise tuning a radio in between stations and then turning up that noise. It's a broadband white noise that can sometimes be listened to that will again draw the patient's attention away from the tinnitus. For people with very severe sleep disturbances, there are some medications that have been found to be effective in some drug studies, not for all people. Now we're talking about a person who has a very serious form of tinnitus that they just can't redirect their attention away from it. And if it's disturbing their sleep, then there are some medications that can be used usually on a short-term basis to try and help the person be able to get back to more normal sleep patterns and be less attending less to the tinnitus, the ringing in the ears. And then for those who can find no way of resolving their symptoms, then counseling needs to be considered. There is something referred to as tinnitus retraining therapy. It's a technique that is being used now by audiologists and otolaryngologists and some other hearing health care providers, in which counseling is used to try and help the person come to terms with the tinnitus. And again, none of these do anything to the tinnitus. It's there. The idea is that if we can do something to reduce or limit the emotional reaction to the sound that's present, reassure the patient that once a medical evaluation has been completed, that there is no medical condition that's causing the problem, that we can improve this. And then the last ear-related condition that I want to talk to you about is imbalance. So we've spoken about hearing loss, tinnitus, and imbalance. The balance mechanism is part of the hearing mechanism. They're both part of the same system. And so in the elderly population, there's an increased incidence in reports of imbalance. The word dizziness is used, the word lightheadedness is used, the phrase, I feel like I'm going to faint, unsteadiness and vertigo. All of these different things refer to different kinds of balance conditions of imbalance. Generally, the symptoms are categorized into 4 groups. Near syncope, when the person has sensation as though they're close to fainting. Cardiovascular and cerebral vascular conditions need to be evaluated very closely if the person is under care for those conditions, if their medication's been changed and so forth. That may be the reason for the onset of the symptoms. Once the cardiovascular or the cerebral vascular condition is under good management, sometimes those symptoms will go away. The CNS, central nervous system, is oftentimes the source of conditions of disequilibrium. True vertigo is a peripheral vestibular problem. It doesn't, first of all, as a symptom, is not nearly as common as the other symptoms of imbalance. And although it requires an evaluation by an otolaryngologist, frequently, or it's very infrequent that the elderly are reporting this sensation of movement that we describe as being true vertigo. And then the catch-all category for those conditions that don't fall in anything else, don't fall in any of these other categories, and the question to be answered is there a psychogenic origin that requires attention? As many as 20% of the elderly population who are living in the community are going to be seeking medical attention for the imbalance symptoms that they experience. And by the time our patients have reached the age of 75, it's one of the most frequent symptoms that they're reporting. And once again, there are a number of medical conditions that are in combination the source of these symptoms, and then when they're not, sometimes it's the medical management, the prescriptions that the patient is taking that sometimes result in the sources of these symptoms. The challenge to the primary care provider is that the differential diagnosis is very broad. There's well over 80 different etiologies for dizziness that would have to be considered. And in some of these instances, the potential workup is going to be very costly. In the elderly, the imbalance conditions that do exist oftentimes are benign and self-limiting, and they're going to be recurring. That's good to know, but when the patient is presenting the problems, you're trying to decide whether or not they're in that category or not. When you finally reach that conclusion, then there usually are more important things to worry about, but you need to convince yourself that there are not conditions that need attention. So this requires that the primary care provider know his or her the epidemiology of their clinical population, so that they have a good idea of what's the most common sources, look at those first, and so forth. And then a good portion of the information and decisions about consultations and so forth is going to come from a careful history and a focused examination on the various symptoms. The question needs to be answered: is the dizziness attributable to the known or suspected diagnostic entity that the primary care physician has touched upon? And if not, then what additional tests are going to contribute to making the right decisions for their patients? So if the condition is relatively benign and there aren't the red flags that would suggest that there's a life-threatening condition, then the decision has to be made whether or not further testing is likely to identify a treatable condition. And those are the things that I have to say. So, what questions?
With hearing loss that's related to, say, high noises from machinery,
Right.
and those are just as, a hearing aid is going to be just as effective with those types of hearing loss?
Yes, quite actually, the damage that takes place in the cochlea and the inner ear from noise is very similar to what takes place in presbyacusis. It just happens over a shorter period of time. And so it's a sensorineural hearing impairment. After the hearing impairment has reached a particular point, Once the communication problems have reached a particular point, then the person with the hearing loss will benefit from hearing aids and from the management that's available in trying to solve the problems that they have.
Even with the use of hearing aids, even in the elderly with the sensorineural loss, I mean, you're going to still see progressive hearing loss. The hearing aid that they say are initially fitted with, is that going to work down the line 5 or 6 years when their hearing loss has progressed?
The answer to that is it depends on the hearing aid. Now, as recently as 3 to 5 years ago, that was not the case, that we only had a limited amount of range of increasing the amount of amplification that the hearing aids provide. With a good number of the hearing aids that are available now, they can be adjusted for a person with a very mild hearing loss and a person with a very severe hearing loss. Generally, the people who have a profound hearing loss who are going to benefit from hearing aids always have to wear a different type of hearing aid. But for the rest, the circuitry that's available and the control, the microcircuitry that controls those circuits has a broad enough range that if a person starts with a mild hearing loss and then within the next 2, 3, or 4 years their hearing has changed, oftentimes the same hearing aid can be adjusted to accommodate that hearing impairment.
With so many of the elderly, it seems like we see more and more of the cerumen blockage. Is that just because they don't clean their ears well, they don't have someone to do it for them? Is that just an aging process? What is that?
Well, there are a couple of different answers to that, and they probably all apply to a different degree. The cartilage that makes up our external auditory canal and pinna changes over time. It begins to collapse. The orientation of the external auditory ear begins to change, and so that self-cleaning process, and really the reason that we have earwax is so that the ear can clean itself. That process has to change because the direction of the earwax and so forth and how it is extruded has to change. So that's part of the problem. And then the ability of our bodies to produce oil, and cerumen is produced in part by sebaceous glands that are producing an oil that then accumulates and collects dirt and debris and so forth, and that is what earwax is. That begins to change, and so that can have an effect on the accumulation of earwax and so forth. If people start wearing hearing aids, you're sticking something in the ear, and that sort of disrupts the cleaning process. So actually solving the problem of hearing loss may be part of then introducing earwax problems that didn't used to exist. And so that has to be dealt with. So all of these different things can contribute to that. At the same time, if we look at the same age population in nursing home and those living in the community, it appears as though the accumulation of earwax and so forth seems to be greater in the nursing home population, and that generally is attributed to the loss of the self-hygiene kinds of things that help in cleaning the ears, although many injuries to the ear are caused by people who are doing their own cleaning. You're supposed to leave your ears alone and have the primary care physician take care of removing the cerumen.
Well, in that line of thought, though, if you have these people who can't clean their ears and you don't have a primary care physician that comes out and routinely does this for them, what is the nursing home setting to do to prevent this problem? I mean, they tell you not to stick anything bigger than your elbow in your ear, so how do you clean the cerumen out? So the answer to that question is under the direction of the now we're back again. Under the direction of the medical director, non-physicians can be trained to do some of this simple ear cleaning. Some of the over-the-counter systems that are available can be used in the nursing home environment, and it will solve some of the problems. But don't they have to be used on just almost a routine every week basis, every day basis?
No, it's not that frequent. It certainly has to be done regularly, but if I had to put a number on it, I would say it'd be something that would be done monthly or maybe every other month, something like that. The earwax ought not to accumulate that quickly. But nevertheless, it's done best, and the fewest complications come when someone who is trained and who can look in the ear can do the removal of the earwax and so forth. There are other less sophisticated solutions to keeping the ear clean and so forth that will nevertheless work. But that's obviously not going to be satisfactory for all the patients. So not doing anything at all, then it just collects. And then if you can find a system that works and it only works for some of the patients, that's great. The ideal situation is that all of our patients in nursing homes would have primary care providers who would be able to do that in addition to all of the other services that the patients need to keep them in good health.
Do you recommend routine ear irrigations? When I used to work in MHMR, we routinely, on all of our children, had to do quarterly ear irrigations, which we all absolutely hated to do.
And so the answer to that is it should not be done any more frequently than is absolutely necessary. As long as the ear canal is not completely blocked, then sound is getting through and the amount of hearing loss is going to be almost minimal. We're really talking about accumulation of wax that is completely blocking the external auditory canal. So it ought not to be done any more frequently than is absolutely necessary. So that requires a careful examination of the external canal with a otoscope. If it's done regularly, sometimes the accumulation can be kept to the point where no additional extraordinary measures are needed. It's going to be different. Some people don't need very much oral hygiene at all, and some need a lot. And so once you've identified those people, then they're the ones who are going to need more frequently. But once again, I think that would most likely be no more than monthly or every other month. And again, you wouldn't do it any more often than you needed to. So, are there any other questions from the other sites? Okay. Okay, are there any other questions from the other sites? I'm getting a great view from El Paso. Okay.
What goes up must come down. Spinning wheels